Good evening. My name is John Dolan. I'm chairman of the Dolan Lecture Committee. I wanted to recognize the 25th anniversary of the Dolan Lecture. It is also a pleasure to recognize the hard work of the Dolan Lecture Committee and the distinguished speakers who presented during those years, and especially to thank tonight's speaker, Dr. Wood. As we reach the milestone of 25 years, it is fitting to describe my father, to remind those who knew him, and to give a sense of who he was for those who didn't know him. My father was part of the greatest generation. That was so eloquently described by author Tom Brokaw. He was a hardened Depression generation of New Englanders who survived the devastating hurricanes, similar to the Hurricane Sandy, including the great New England hurricane of 1938. He and his brothers battled the fierce elements to rescue many that day, something he has seldom talked about, but something he simply did. He was determined to get into medical school and worked at night as a guard at a federal building to help pay his way through Georgetown Medical School, something he simply did. He landed on the beaches of Normandy on D-Day, set up a mobile hospital for the wounded on the beach, then moved on with the Army through France, Italy, and Austria, and then on to assembling pathological data for the Nuremberg trials, something he did and that I didn't learn about until I read his obituary. He excelled in the medical profession and focused his life on developing a community hospital, enhancing the quality of care by initiating the first teaching affiliation between a medical school and a community hospital, with the affiliation of Georgetown Medical School. His commitment to medical education led to his involvement in the creation of the American College of Pathology, as well as being a clinical professor, assistant dean of Georgetown Medical School, all which he simply did. So after only mentioning some of the things my father did, I was thinking how to tie this into the Dolan Lecture that honors his memory. I thought of a recent soccer scrimmage that I was drafted into playing with my son, Jack Dolan, and his cohorts. That as I entered the game, I was barking orders and advice while trying to manage the ball with my feet. After having the ball taken away from me for the third time, I was giving instructions to some of the players to break forward, and I passed them the ball. And I heard Jack Dolan yell, "Stop talking, Dad, and just do it." So I think it should be our continuing goal for obtaining excellent quality of speakers that the Dolan Lecture has presented in the first 25 years, that this should be our goal. Like my father, and as summed up by my son, Jack's admonition, let's not talk about it. Let's simply do it. Thank you.
Good evening. My name is Patrick Correnti. I'm an internal medicine doctor here at the hospital center. I joined the ranks of the hospital in 1998 after I finished my residency at Georgetown. And when I got down here from Pennsylvania, from med school, this is the place I wanted to be. This affiliation that Dr. Dolan had set up so many years ago was so true to my heart and so true to where I want to be. To serve this community, to serve where we could, and to strive for excellence. Excellence is based on what we do. A wise person once said, we won't be judged by our intentions, but by our actions. And Dr. Dolan really strived for excellence. He strived for excellence for this hospital. He strived for excellence for this community. When I joined the Dolan Lecture Committee in 1999, it was an exclusive committee of some of the top doctors in this hospital. I felt honored and privileged to join the ranks of these. Dr. Ryan and Dr. Nolan, along with Dr. Dolan, always reminded me of my place. They reminded me that they pulled me out of the gutter. When I was a resident, I had nothing to offer them and just to sit and listen, which I did. From that time, we've added quite a few members to our Dolan Lecture Committee. Some of our older members are now emeritus. We strive to continue to bring some of the best leaders of certain fields to our committee and then to our lecture. With having a number of female doctors that have now raised into the presence of Arlington Hospital, Virginia Hospital Center, and to the level of care that they are providing, now with most medical schools, either 50% women or more than 50% women, it's an honor to have this addition to our committee. And this year we invited Lisa Kelly to join us, a pediatrician, which is our first pediatrician on the board. And this, as I told Dr. Wood, is one of our first lecturers. Dr. Dolan strived for excellence. You can see it in his offspring. 3 terrific kids that he loved and cherished dearly. Excellence goes generation after generation with Jack Jr., with Tom Dolan, the Olympic swimmer, with Kathleen Dolan, a lawyer. And you can see it carry on. But excellence for this community has been building this hospital, being a severe philanthropist at the uttermost level to make this hospital work. I can only tell you the stories as I got to know Dr. Dolan later in his years of how they couldn't pay the bread truck when it was being delivered here because there was no money. They weren't sure they were going to make it in the late 40s when the hospital first opened and Dr. Dolan came on. As time went on, this hospital grew, the affiliation with Georgetown grew, and as I look out in the audience, I can see a lot of my peers, a lot of doctors from Georgetown, and it's an honor to be practicing with all of them, along with every doctor that's on our staff here from any university. We've built a great hospital here through the legacy of not only Dr. Dolan's philanthropy, but the community's philanthropy, who started the foundation for this lecture series years ago. As you can see from the lectures that we've had in the past 25 years, excellence stands out. From Dr. Fauci in the beginning of the AIDS epidemic and giving us insight, to stem cell research, to Dr. Wood now giving us on allergies, we're honored to have all these people at our community service. We've opened up the lecture. As times have changed, we've had to change also. The lecture series now tries to include community members, knowing that our band of knowledge goes wider than just the physicians on staff here, that it goes into the community. That knowledge should be available to everybody. I'm honored to stand here tonight. I'm honored to be part of the legacy of the Dolan Lecture Committee and 25 years of a strong lecture series will continue. Thank you very much.
Hi, my name is Lisa Kelly. I'm a pediatrician at Northern Virginia Pediatrics, and we see newborns here at Virginia Hospital Center, and my great pleasure to be able to introduce Dr. Wood to you tonight. Dr. Wood received his MD from the University of Rochester School of Medicine, then completed his residency and his fellowship in allergy and immunology at Johns Hopkins Hospital. He has since become, as many of you know, and that's why you're here, a leading expert in the world of allergy and immunology. He has taken the helm of the department at Johns Hopkins, where he trained, and is now a professor there and the chief of pediatric allergy and immunology. He is also a professor in the School of Public Health at Johns Hopkins. And as I said, you all know that he is recognized as an expert in food allergy and childhood asthma. He has published hundreds of articles in scientific journals, written multiple chapters in allergy and immunology texts, and written books for physicians as well as for patients, including Food Allergies for Dummies. He has served on the American Board of Allergy and Immunology, and is currently on the board of directors for the American Board of Pediatrics and the American Academy of Allergy, Asthma, and Immunology. As a parent and a pediatrician, I know oh so well how food allergies have come to be part of all of our daily lives. We cannot send our children off to school or arrange a play date without having to ask, is your child allergic to anything? Is there anything he can or can't eat? What about peanuts? Fruit? What? You don't eat strawberries? Who? So people ask questions all the time, and Dr. Wood is the expert that we all look to. He is he is often the go-to person in the Mid-Atlantic region, and perhaps even the nation, on pediatric allergies, and it gives me great, great pleasure to bring him here to you tonight. Thank you.
Thanks, Lisa. It's a pleasure to be here. It's an honor, as well as a pleasure, to be speaking on behalf of the Dolan Lectureship. I think as the 25th anniversary, it makes it even more special for me to be here. So I thank you for the invitation, and will do my best to do justice to this really prestigious lecture series. So the topic is food allergy. We named it To Eat or Not to Eat, Food Allergies in the 21st Century. And the goal really is to give some updates on the world of food allergy as it stands in 2012, looking ahead to at least the next 5 or 10 years in terms of some changes, the potential, the hope to be able to treat food allergy at some point in time, but also to give people here a real framework about the basics of food allergy so that we can really help our patients in the best way possible. So to begin, a definition is important, and a definition is important because there's a lot of ways you may react adversely to a food, and some of them are food allergy and many of them are not. In fact, of everyone who complains of an adverse food reaction, most of them are actually not true food allergy. So you need to differentiate this adverse food reaction from a food intolerance or other ways that a food may bother you. And there are a few components that make food allergy different from other adverse food reactions. The most important of which being that this is an immune system reaction. This is an immunologic response, and it is typically an immunologic response to a food protein. And most food intolerances are a problem digesting a carbohydrate of the food, whereas food allergy is an immunologic reaction to the food protein. With food intolerances, it may take quite a lot of the food to cause a reaction, but with food allergy, very small amounts may cause a problem. And as we'll discuss, food allergy can cause reactions that are severe, sometimes even life-threatening, and sometimes even fatal. Just a little on how someone may or may not develop a food allergy, and this will be relevant as we think, not with any answers, but with thought about why food allergy has become more common and whether there are things we might be able to do to prevent or reduce food allergy. But in a general sense, we think that food allergy begins with some exposure. That exposure may be as early as in utero. It may be during breastfeeding. It may be with early introduction of foods. But it usually is very early in life, so most food allergy does develop in the first year or two of life. And with this food exposure, you can go in a couple directions. And thankfully, most children go in the direction of tolerance. Most children learn immunologically to accept and tolerate that food they've been exposed to. But there are another group of people, and I'll show you right now, it's 5 or 6 or 8% of young children who go in the wrong direction, and instead of learning to tolerate a food, develop what we refer to as sensitization, the beginning of the immune response to that food. And in that group of people, when they have re-exposure to the food, it can then lead to the symptoms of an allergic reaction. We think there are a lot of factors that relate to which direction an individual goes, which direction their immune system goes. And some of them are genetic, so that we think there's a genetic predisposition. There's some people who are much more capable of developing a food allergy than others. Many of them are probably environmental. And when I say environmental, we're talking here in very general terms. We're talking about diet. We're talking about viruses. We're talking about vitamins. We're talking about other illnesses. We're talking about stress, other things that may affect the immune system. And somehow, with some wrong combination of events, probably some genetic predisposition, but then something else that went on with these environmental stressors, this group of people go in the direction of food allergy. Now, the prevalence of food allergy is something that's a little hard to get an exact handle on, partly because different definitions are used, partly because it really does appear to be a moving target, moving in the wrong direction, becoming more common with time. But the numbers that we believe are accurate right now are that 6 or even 8% of young children have honest-to-goodness true food allergy. That number drops to 3 to 4% by late childhood, adolescence, or adulthood. That means at least 11 million Americans have a true food allergy. And as we'll talk about a little bit later, the prevalence appears to be rising rather sharply worldwide in developed countries. So as we look, say, to Northern Europe, if we look to Australia, if we look to Japan, there are very similar rates of food allergy. The exact foods that cause the problem may vary a little bit, but the rates of food allergy are very similar and appear to be rising in a similar fashion around developed countries around the world. Now, this is a slide just to put in context food allergy with the other common allergic diseases. And there are 4 allergic diseases that travel in the same circles. Those diseases are food allergy, eczema, referred here as atopic dermatitis, asthma, and allergic rhinitis. Now, there's other allergic things. There's drug allergy. There's bee sting allergy. Those don't travel together as these do. And the purpose of this slide is to show you a couple things. One thing is that the onset of food allergy is early in life, and that the peak prevalence with food allergy occurs really at about 1 year of age. Food allergy then has a fairly steady plane for a little bit, then a gradual decline until you get down again to this 3 to 4% of people with food allergy later in childhood, adolescence, or adulthood. The second point here is that respiratory allergies like asthma and allergic rhinitis have a slightly later onset, and they actually don't hit their peak prevalence until adolescence or early adulthood. The other thing that is not seen on this slide, but is actually the most important point of this slide, is that these 4 curves don't represent 4 separate children. They actually typically occur together. And as every pediatrician and a lot of parents in the audience know, any child who shows up in your office in the first year of life with food allergy and atopic dermatitis will probably go on to develop allergic rhinitis and asthma by the time they're school age or even earlier. Now, there's over 200 foods that are well defined as food allergens, again, meaning the kind of foods that can stimulate the immune system to cause an allergic reaction. But the list that we deal with on a day-to-day basis in regular practice is relatively short. On the early childhood side, it includes milk, eggs, soy, wheat, peanut, tree nuts, fish, and I have sesame in parentheses because that's something that appears to be showing up much more commonly, but we don't have exact numbers as to its prevalence. And then the list is a little bit different when you look at adolescents or adults. And the list there is peanuts, tree nuts, fish, and shellfish. And this list changes for 2 reasons. One reason is that some of the most common allergies in childhood are often outgrown. Milk, egg, soy, and wheat allergies are usually outgrown, so about 80% of children will outgrow those allergies eventually. And the second reason the list changes is that for reasons that are not terribly clear, we have some theories, but reasons that are not terribly clear, fish and shellfish allergy are unique in that they often have a late onset, so that the most common age to have a shellfish develop is actually in adulthood, not in early childhood, as we see with milk, egg, soy, wheat, peanut, and tree nut allergy. And these are just some relative numbers, not to memorize, but just to give you a sense of how these compare to one another. So around the world, milk allergy is the most common food allergy in young children. About 2.5% of young children have true milk allergy. Egg allergy, about half as common as milk allergy. Peanut allergy, a little bit less than that. We think of peanut allergy as being the most common allergy. It's not. By the time you get in later childhood, it may be, and that's because a lot of the milk and egg allergy have been outgrown so that the prevalence as you get into adulthood of those is just a fraction of the childhood prevalence because, again, about 80% of those allergies are outgrown. Peanut allergy, on the other hand, is only outgrown about 20% of the time, so that has a higher prevalence compared to milk or egg when you look into adolescents or adults. And then again, we get down to this overall prevalence rate of about 6%, maybe even as high as 8% in children, and 3 to 4% in adults. Now, the signs and symptoms of food allergy are confusing because they range so widely, and it's confusing to everyone. It's confusing to parents. It's confusing to doctors. And it may present from things that are very subtle, very chronic, very low grade, to things that are very dramatic, very obvious, and really easy to diagnose. But when we try to divide them into two categories, the chronic low-grade food allergies are those that involve the skin with a presentation of eczema, and those that involve the GI tract with more low-grade symptoms of vomiting, diarrhea, and in children, poor growth may be a manifestation of food allergy. And these are allergies where your history will almost never pinpoint the food they're reacting to, and it won't pinpoint it because the symptoms are delayed and low grade, so that people won't be able to say that their stomach hurts worse after having that extra glass of milk, because it may actually be the milk from the day before that made their stomach hurt today. The more acute food reactions, again, include the skin, but now not with eczema, but with hives or swelling angioedema. Again, they may be involved with the GI tract, again with vomiting or abdominal pain. But here we're talking about an acute onset. So you have that bite of peanut butter, and within minutes of having that bite of peanut butter, you're vomiting and have abdominal pain. There can be respiratory symptoms of cough, congestion, wheezing, and breathing difficulty. And these are usually more acute. So when a patient comes in with chronic respiratory symptoms, somebody with chronic congestion or asthma that's been a little hard to control, we don't think of food allergy as a first consideration for what's triggering their respiratory symptoms. But in the acute setting, having these respiratory symptoms is very important, and actually the most common cause of really dangerous allergic reactions is respiratory collapse. Cardiovascular symptoms include hypotension and shock. Then anaphylaxis is the word that describes a more systemic allergic reaction. And with anaphylaxis, it's typical to have multiple organ system involvement. It is as with the other acute onset allergic reactions, very quick after eating the food, so that 90% of all acute food allergic reactions occur within 30 minutes of eating the food. It can occur up to 2 or 3 hours later, but that's very uncommon. The vast majority show up within minutes, 30 minutes at the longest. We think of anaphylaxis as always being dangerous. Some anaphylaxis is relatively mild, relatively self-limited. Some anaphylaxis will resolve on its own. But it can range from those mild self-limited reactions to life-threatening and fatal reactions. One of the problems, as I'll point out, is that you cannot necessarily early in the course of a reaction predict where that reaction is going to go, so that it may be very hard to know when you've eaten that food and begin to have a few hives, whether you're going to stop with a few hives or whether you may have life-threatening symptoms even 15 or 20 minutes later. There are not a huge number of fatal reactions from food allergy, but they do occur. We estimate between 150 and 200 a year in the United States. And most importantly, there are a few very well-defined risk factors for a bad outcome from peanut-induced anaphylaxis. And these hold up almost universally. So when you look at all of the series that we've done on fatal food-induced anaphylaxis, virtually all of them are due to peanut or tree nut allergy. Virtually all of them occur in people with coexistent asthma. And even most importantly, is that almost all have had a delay in epinephrine administration. And I say that one being most important because that is the one that we as their caretakers at least have some control over. I cannot control whether my patient with peanut allergy has asthma. I may be able to control their asthma better. That may actually reduce their risk of a severe reaction. But I can't take care of the first two risk factors, but I can hopefully limit or eliminate the last risk factor, which is not getting treated with epinephrine promptly. A couple of myths about anaphylaxis. One of the myths is that anaphylaxis always presents with cutaneous manifestations. And in reality, about 20% of cases don't. But more importantly, when you look at the series of fatal, near-fatal, food-induced anaphylaxis, most of them don't have cutaneous symptoms. And that's kind of scary. If a patient relies on the fact that they usually get hives when they have a food reaction, and this time they don't get hives, but all of a sudden they can't breathe, they may misinterpret that as an asthma attack or something that could be treated with something other than epinephrine. And this is a very common scenario in the fatal or near-fatal food-induced reactions. And the second myth that is very important is that future reactions can be predicted by prior episodes. And it turns out this is not only not a little bit untrue, it is dramatically untrue. And the reaction pattern can vary dramatically over time. There's no predictable pattern. The severity of a reaction depends on a number of factors. The factors are the sensitivity of the individual. So you will have some patients who are at higher risk for bad reactions because they are truly more allergic. But the thing you can never predict is the dose you're going to get exposed to. So this highly sensitive individual with one exposure, let's say back to peanut, gets exposed to a contaminated cookie that has 1/200th of a peanut on it. And they have a mild reaction potentially, probably with that very low exposure. And on their next exposure, they get actual peanut, and they get the equivalent of 5 peanuts in this cookie. And the fact that they got a 1,000-fold higher dose means they will have a much worse reaction, and that's something you can never predict. The route of exposure may have influence, although with food allergy, ingestion is the route that is going to be most dangerous. Patients worry a lot about contact exposure, airborne exposure. They occur, but they're rarely the cause of severe reactions. And there are other factors, and again, we'll come back, especially asthma. And this may be most important in the fact that asthma is not a static disease. And at the point in time a patient has very stable asthma, the influence of their reactive airways on their food reaction may be considerably less than at a point in time when their asthma is less under control. So if you have the bad misfortune of having an allergic reaction in the midst of a viral infection where your asthma is flaring, you actually have a much greater chance of having a severe respiratory reaction. Now I'm going to talk to you a little bit later about some of the treatment studies we're doing for food allergy. And it's been through these studies where we are intentionally exposing people to food to which they are highly allergic, where I've become fully educated, I never was before, on the unpredictability of reactions. And there we will see people who will take the exact same dose, measured on a very precise scale, for 20 days in a row with no reaction. On the 21st day, have a mild reaction. Take the same dose for 20 more days, and on the 41st day have severe anaphylaxis from that exact same dose. And parents are dumbfounded. We're a little dumbfounded, but we've come to recognize that that is how unpredictable reactions may be. So the natural history of food allergy is thankfully generally a positive one, meaning that a lot of food allergy is outgrown. And as I mentioned earlier, for some of those common pediatric food allergies, milk, egg, soy, and wheat, a majority of them are outgrown by the school-age years, about 80% eventually. Now, the thing that's changed there has been an apparent slower decline, slower rate of outgrowing, a somewhat smaller percentage that eventually outgrow it. And the example there would be in the 1990s, we did a study showing that about 80% of children outgrow milk allergy by the age of 3. And then 20 years later, we did a study showing that 50% still have milk allergy at the age of 10. So there is apparently some change not only in the prevalence of food allergy, but potentially in the natural history of the disease. Now, one of the things that's been most interesting as we've moved through our treatment of food allergic patients is this bullet here. And if I showed you this slide 10 years ago, I would have said very clearly the process of outgrowing a food allergy would be helped by strict avoidance. Wrong, wrong, wrong. Turns out that exposure actually promotes development of tolerance. And that doesn't mean everyone can be exposed. There's some people who are too allergic to be exposed, and it's too dangerous to expose them. But what we've learned is that if there is an amount of food that patient can tolerate, it may actually be perfectly reasonable to incorporate it into the diet. That's become especially clear in the last 8 or 10 years with milk allergy and egg allergy. And what we've learned with those foods is that when you extensively heat the food, as in baking, you break down the protein sufficiently that it becomes much less allergenic, but that having the exposure to that less allergenic protein can actually promote the development of tolerance to uncooked, concentrated milk or egg. And that's been a very dramatic change in how we've managed patients over the course of the last decade. Now, allergy tests I'm not going to talk about in this lecture, but allergy tests are remarkably inaccurate. They'll often be positive when people are never allergic, and when you've outgrown a food allergy, they'll usually still be positive. So we're not waiting for a test to be negative to think that someone might have actually outgrown their food allergy. Then the exceptions to this positive natural history is that most peanut, tree nut, fish and shellfish allergy are usually lifelong. We've done studies to show that about 20% outgrow peanut allergy, about 10% outgrow tree nut allergies, but the other 80 or 90% who develop these allergies, again, typically early in life, will carry them through life into adulthood. Now, another important idea here is not just the natural history of food allergy, but what happens to that food allergic child. And that third slide I showed you with those 4 curves was to sort of introduce this idea that if you have one allergic condition, you have a good chance of having other allergic conditions. So when you're taking care of a child with food allergy, and food allergy, because it has this very early onset, is often this child's first manifestation of their allergic predisposition, we know that at least 30% of, say, children who show up in the first year of life with a milk or egg allergy will develop other food allergies. At least 90% will get allergic rhinitis. And depending on the study, at least 50%, but probably closer to 90% will go on to develop asthma. There's a huge interest in whether we can do anything about this. Is there a potential role for preventative measures? Is there something we can do? And I'll talk about allergy prevention in a moment. I'll talk about it in a rather pessimistic view that much more of this is out of our control than under our control, but there's still some ideas that are under investigation that may have end up having some merit. So the care of the food allergic child is that we need to pay very close attention to these kids. We need to regularly assess their growth and nutrition. This is a combined process from the pediatrician and the allergist. We need to monitor adherence to the diet. We want to review reactions and accidental exposures, and this review is really important for 2 very different reasons. And one is that we may have had a more severe reaction than we expected. We might have underestimated that child's potential to have a bad reaction. And in that case, we need to redo, re-review, remake their action plan. We need to give them a new plan for how to deal with their next reaction. The opposite end of the spectrum is one that we hear about a lot, thankfully, and that's that they had an accidental exposure and didn't react. And that may give us a sign that they're on their way to outgrowing the allergy. Or say that child that's had a milk allergy ended up getting a cookie that has milk baked in it and didn't react. And that may be a sign that even if they still have milk allergy, maybe they can tolerate baked milk now. Maybe we can help change their quality of life by introducing those products into their diet. We retest on a regular basis, usually annually, up until the allergy picture is clear. You do hit a point with things like peanut allergy where there's really not value in repeat testing over time because they've shown you they have persistent allergy and they've told you it's really not necessary to test them again in the future. But for the allergies that they are more likely to outgrow, and even some kids who have lower levels of peanut allergy, it is worth reevaluating them on an annual basis. And the reevaluation includes blood testing to measure allergen-specific Ig levels, sometimes skin testing, and then sometimes oral food challenges being the only test that has the capacity to truly identify whether someone is truly allergic or whether that person has outgrown their food allergy. But those are only done if indicated. If a child has had recent reactions, you don't need to formally challenge them to prove that they react. If their test scores say it's not appropriate to challenge them because you know they're still allergic, then we wouldn't do it. But they're still very valuable as a method to see if someone has outgrown an allergy. So is food allergy really more common? And if so, why would that be the case? There is a lot of evidence to say it is truly more common, that what Dr. Kelly mentioned in the introduction about how food allergy is such a common concern in pediatric practice, in schools, how school nurses say, 20 years ago they had 1 EpiPen and now they have 40. These are not rare stories. There is probably a little bit of detection bias where we're more aware of it. There probably is some overdiagnosis with people being called food allergic who are truly not because our tests are not that accurate. But in the studies that we've done where we've used same methods to reevaluate prevalence of food allergy over the last 20 years, all of them come up with a similar answer. And they come up with a similar answer whether that study is done in Maryland, the United States as a whole, Canada, Australia, Japan, Sweden, England. They all come up with a similar number, that food allergy is about 3 times more common now than it was 20 years ago. Peanut allergy gets the bulk of the reputation, and we have good studies to show that peanut allergy is about 3 times more common now than it was 20 years ago. But there is no evidence actually that peanut allergy has risen more rapidly than other food allergies. Our personal opinion and some studies, and there are a lack of good studies, but would suggest that other food allergies have risen at a similar rate as has peanut allergy. There are a lot of theories as to why food allergy has gotten more common. It's also important to recognize that the rise in food allergy is not unique to food allergy. It's actually common to the other allergic conditions. One of the interesting things is that though it appeared that asthma rose earlier, the peak rise in asthma occurred in the 1970s and 80s, whereas food allergy didn't really take off until the 90s and 2000s. So there are some interesting distinctions there, but there have been similar increases in the other allergic conditions of eczema, asthma, and hay fever over the last 20 or 30 years. So a lot of theories about this, and we spent a lot of time talking about these theories. There are absolutely no clear explanations, but some of the theories that are out there, the most popular, the most common being the hygiene hypothesis. The hygiene hypothesis says that we live in too clean an environment, and that if the immune system early in life is not sufficiently challenged with microbes, infections, other bacterial exposures, they may have more time to focus on things like allergy. And I'll talk more about the hygiene theory on the next slide. There are theories about our diets. And when we think about these theories, we need to think about, okay, it doesn't make sense, but also, has it really changed in the last 20 years? Is this something that you can say, yeah, when I look back at the 1970s, we're doing things differently now. I think our diets are different. We eat a lot more processed food. There are less healthy diets. There's more use of pesticides. So that is something that's on the list. The evidence is not very strong to suggest that's a big factor in the rise in food allergy, but it's certainly on the list. There are some specific nutritional factors that are very interesting. And the two that have come to the forefront are vitamin D and folate. They both make sense temporally in that there is a much higher rate of vitamin D deficiency now compared to 20 years ago. And that relates to spending more time indoors. It relates to more sunscreen use. But across the board, in all populations in developed countries, there's a higher rate of vitamin D deficiency. Another one is folate. And both vitamin D and folate are known to have potent effects on the immune system. So from a scientific standpoint, they actually make some sense. How does folate fit in? Folate fits in that the rise in food allergy coincides exactly with the use of prenatal vitamins. At the same time that became routine, food allergy took off. We don't know the cause and effect, but we have several studies now to show that excess folate intake is a risk factor for developing asthma and other allergic diseases. Immunizations are always on the list because people want to pick on immunizations. Not a lot of evidence that immunizations have contributed to this. But it is on the list. Antibiotic use is on the list, partly as a separate phenomenon, partly as a factor in the hygiene hypothesis, because if you are on antibiotics, then your own bacteria, which may have effects on your immune system, potentially to slow or prevent the development of allergy, may be influenced. And there are clearly studies to show that excess antibiotic use is associated with development of asthma. There's not evidence for food allergy, but it could develop. The problem with the asthma studies is that we know that kids that have respiratory disease end up in antibiotics more. So whether it's cause and effect or just the same kids who have asthma tendencies getting more antibiotics is entirely possible. Many, many other theories, and I'm sure there are others that we've not even thought of yet and not yet explored. The hygiene theory is, again, the one that gets the most attention. Is there truth to the hygiene hypothesis? And there are some things that really make sense. And one of them is that there is a lot less allergy in less developed countries. And as countries become more developed, and more developed in a lot of ways means clean water. When your water gets clean, allergy takes off. And that actually makes sense from the hygiene hypothesis, that if your immune system in your first year of life is really kept busy dealing with bad water, it's probably not going to spend a lot of time focusing on whether they care about peanut allergy or not. There are many studies now showing that animal exposure may help prevent allergy. Not food allergy, but asthma and allergic rhinitis. And animal exposure is, the effects are most prominent when you look at rural European communities with heavy exposure to cows. Cows are actually very protective against allergy. But in the United States, dogs are protective against allergy. Family size, so smaller family size associated with more allergy. Being a first child versus a third child is a higher risk of allergy. Being put in daycare early is protective against allergy, again, probably because you get exposed to more germs. And cesarean section across the board is associated with a higher rate of allergy, again, because the bacterial milieu of a vaginal delivery probably has got very beneficial effects in developing your personal microbiome that may help keep your immune system in check. Now, with all these things, there's a lot more evidence for asthma and allergic rhinitis than there is for food allergy. And there are many, many holes in the hygiene theory, which is why we can be quite convinced that this is not the sole answer to why food allergy or other allergies become more common. And the biggest hole in the theory is seen in my clinic on a daily basis, where we take care of a large population of patients in urban Baltimore. And patients living in urban environments actually have the highest rates of asthma and allergy. They should have all the benefits of poor hygiene, and somehow it doesn't manifest with less allergy. And there must be some different balance in different communities. They may be exposed to other things that can have more potent effects in a pro-allergic direction to counteract anything that might protect them from poor hygiene. And can food allergy be prevented? This is a very common question. Again, this is something, if I'd given this talk 10 years ago, 15 years ago, I would have said, yes, it can, and here's the things we should do. And now I say, probably not, and here's the things we talk about, but probably don't work. So we talk about whether the mother's diet during pregnancy or breastfeeding makes a difference. It actually makes a little difference, but doesn't seem to make any huge effect by avoiding or not. Hypoallergenic formulas other than straight milk formulas or straight soy formulas do have some preventative effects compared to milk-based formula, but they're not really more protective than breastfeeding, so it doesn't, there's no reason to not breastfeed to use one of these formulas. It's been theorized that if you delay introduction of solid foods or delay introduction of allergenic foods, when I talk about allergenic foods, we're really talking about milk, egg, and peanut, the three most common food allergies. Now I have a new bullet here, early introduction of allergenic foods. Because that's the theory now, is maybe you should really get them in the diet early. There's no evidence to really support either. So anything we're really saying now is really not based on fact. There are some epidemiologic studies, such as to say that kids in Israel have a lot less peanut allergy than Jewish children in London. And the theory is that in Israel, they're given a peanut snack called bamba, beginning as a finger food at 6 to 9 months of age, and maybe that's the reason they're protected against peanut allergy. But this is circumstantial evidence. It's by no means data that we would use to make recommendations. And my personal bias with this is that if you take, say, peanut allergy, that of all the kids out there, 95% of them, 96, 97%, couldn't get a peanut allergy no matter what you did. Doesn't matter. They don't have the capability. You could put it in their bottle, you can rub it on their skin, you could hold it till they're 10, it doesn't matter, they're not going to get an allergy. And of the other 2 or 3%, I think 1% of them will get a peanut allergy no matter what you do. And probably of the other 2%, half should get it early and half should get it late. So to think that I'm going to give them a clear recommendation is wrong. There's interest in things like probiotics, a lot of interest in probiotics. And probiotics, again, are really taking advantage of that hygiene theory, saying that if we can populate the GI tract with good, healthy, protective bacteria, maybe that will help prevent allergy. So what we currently recommend is really very vague. We do have a study that showed that peanut ingestion during pregnancy was a big risk factor for peanut allergy in our population. So and here I'm talking about high-risk families. I'm talking about families that I'm taking care of already because they have an affected child. I would not make any of these recommendations to a well-child family out in the community. But you could consider, in this high-risk family, avoidance of peanuts and tree nuts during pregnancy and possibly while breastfeeding. If they do want to use a formula, there is evidence to suggest that supplementing with a hypoallergenic formula is valuable. There's no evidence that delaying solid food introduction beyond AAP recommendations is beneficial, but really early giving solid foods at a month or two of age is potentially harmful. And we really don't make any specific recommendations now about introduction of allergenic foods like peanut. We tell families if they want to introduce it in their 9-month-old, they can. If they want to wait till they're 3, they can. We really don't think that there's a reason to believe that we can make a big dent in the development of peanut allergy by how we introduce peanut. I do believe that once a patient has shown evidence of developing food allergy, that early intervention can be beneficial, and I've highlighted the word not just early but individualized, because individualized can mean very different things. And for one child it may mean just getting them on the right diet so that they start to grow and their eczema calms down. Another child may actually be intentionally introducing milk even though we recognize they have true milk allergy, because we believe in that individual child that early introduction may promote tolerance and that we can do it safely. So the last thing I want to cover over the last 15 minutes or so is this question: is food allergy a treatable disease? And this is something that has gotten a lot of attention and taken a lot of my time and energy over the recent years in a very, very enjoyable way, as some research that is exciting and gives us some hope to be doing something different in the future. Now, why do we really hope to do something different? So when we're talking to people who are not familiar with food allergy, they think, well, who really cares? You avoid the food, and that's not such a big deal, and you treat a reaction if that's what happens. And that has been our approach to food allergy for time eternity. We've had those two things. That's all we can offer people, is to avoid what they're allergic to, and if you accidentally eat it, here are the drugs to use to save your life. So why are those limited? Strict avoidance is not easy. It can have a major impact on quality of life. Anyone who's dealt with a food allergic child who's avoiding lots of foods, it can be very, very restrictive. And when you're avoiding the common foods, the things that are so nutritionally part of our lives, like milk and egg, early in life, that can have significant nutritional risk. So that's not a good approach if we could do something differently. We can wait for allergies to be outgrown, but as I mentioned, some are rarely outgrown. And even of the ones that are usually outgrown, there's at least 20% who never outgrow them. And some of our kids who become adolescents and young adults with milk, egg, soy, or wheat allergy have allergies that are just as dangerous as the worst peanut allergy. These are not less severe allergies. They can actually be very dangerous and life-threatening. And then, of course, we're going to treat reactions when they occur, but even with treatment, reactions can be severe and sometimes even fatal. So our current paradigm, we would argue, is really not adequate. And if we could do something to change that paradigm, we would certainly value that prospect. So there are a number of potential treatments. One of them is using a drug called Xolair, which blocks IgE antibodies. There are some Chinese herbs that are under investigation that have shown some promise in mouse models of food allergy. I'm going to talk mostly right now about immunotherapy, ways to try to teach the immune system by gradual desensitization, the old allergy shot idea for food allergy. And there are a number of ways that we're approaching that I'll describe in a couple of different studies. And I mentioned this idea, and I'm not going to talk about it further, but ingestion of extensively heated milk and egg, again, can not only make life easier, but can help build tolerance in children who can tolerate those foods. So immunotherapy, again, is the word we use for allergy shots. Allergy shots have now been around for a century. We hit our 100th anniversary of the introduction of allergy shots last year. But it turned out when this was tried for food allergy that giving an allergy shot for a food, again, an injection of an attack food protein, turned out to be far too dangerous to move forward with. So the risks were far greater than the potential benefits. There was a study now 20 years ago where a small number of people were given peanut immunotherapy. And the outcome of that study is we spent the next 15 years thinking of different ways to do it because there was a fatality in that study. That a patient in a very reputable hospital sitting in an intensive care unit who got an allergy shot of peanut died in spite of the best possible medical care. So we've been thinking about different ways to do this. And the main different approaches have been other routes of delivery, not giving it by injection, but giving it orally, and what I'm going to refer to as oral immunotherapy, giving it sublingually as a liquid under the tongue, referred to as slit. We're starting a study now in transdermal immunotherapy, applying peanut in a patch to the skin. And then we're working on ways to modify the allergens so you may be able to induce tolerance and reduce or eliminate the risk of adverse reactions. But this is what I'm going to talk about right now, are oral and sublingual immunotherapy. And I'm going to focus on 3 studies that we've done over the last 5 years. Now, the general approach to oral immunotherapy is represented on this slide. And the general approach is that you have a screening evaluation. You decide if this patient is really appropriate to go into this study. We do a baseline challenge, and that's really to characterize how allergic they are. We then begin with some initial treatment, and all the treatment initially is done in the hospital under observation. You might work them up in the milk study I'm going to show you, or the egg study, to 50 milligrams. That's equal to about 1/3 of 1 teaspoon of milk. They then take daily doses at home with increases in doses done every 1 to 2 weeks. So say at this point, they come into the hospital, they take that dose under observation. If they tolerate that dose, they will then take that dose for the next week or 2 and come in and take an escalation under observation. And then we work up to some maintenance dose, and the maintenance dose has changed with our studies, and each study has informed the next study into what might be both safe and effective. We then hit a period of maintenance dosing that goes on for somewhere from 6 months out to 18 months, maybe even longer. We do repeat challenges every year or 2. And then in some studies, and I'll show you 2 of those, we do a study after therapy has been stopped. And the important idea here is that we think that there are some allergy treatments that lead to only a transient desensitization with which the allergy will return after you're no longer exposed to that allergen, and other therapies that may lead to a long-term tolerance. So if you think clinically, if you have a patient with a severe drug allergy and you desensitize them in the intensive care unit to the drug they're allergic to, you'll be able to get them through that 10-day course of penicillin, but within 5 days of stopping it, they will be just as allergic as they were before. So that's a good example of transient desensitization. We know with bee sting allergy shots, if we treat them for 6 months, they'll be protected, but the protection will go away very quickly. If we treat them for 3 to 5 years, most people will have long-term protection without getting any further shots or other exposures. So the first study we started was in 2007, so really everything I'm showing you just has happened in the last 5 years. This was the world's first double-blind, placebo-controlled oral immunotherapy trial. We focused on children with moderate to severe, but most importantly, persistent milk allergy. We didn't think anyone in this study would outgrow the allergy on their own. We compared milk powder, again given orally, to placebo powder. They did this day 1 escalation, starting with a very tiny amount and working up as high as 1/3 of 1 teaspoon of the equivalent of 1/3 of 1 teaspoon of milk in the powdered form. We worked up to a dose of 500 milligrams, which would equal 1 tablespoon of milk. Where did we come up with 500 milligrams? I'll tell you exactly where we came up. Out of thin air is where we came up with it. This had not been done, and safety has dictated everything we've done, so we thought this was a reasonable dose. We didn't know if it would work, but we thought it would probably be safe to try to get to that point. And then this was a short-term study. It was really a proof of concept to see if we saw anything or not. So they only got the maintenance for about 4 months at 500 milligrams daily. And these are the results of the active versus placebo. And on the placebo side, you'll see that no one, not surprisingly, got any better. But on the actively treated side, most people had a significant increase in the amount of milk that it took to cause a reaction. About half of the kids at the end of the treatment got to the full amount, 8 ounces of milk without any reaction. And then the others were still having symptoms, but again at a much higher dose of milk than they had prior to treatment. So the median dose of milk it took to cause a reaction before treatment was 40 milligrams, and the median after treatment was about 6,000. We then took everyone from this study and put them in a second phase of the study where they had an individually determined dose of milk that was continued over the next 3 to 18 months. The time frame varied because some children were doing very well and we re-challenged them on the early side. Some children were still having lots of reactions and we waited to re-challenge them later. But after this next interval, we had, again, most people having increased tolerance. This challenge, we went up to 16,000 milligrams of milk, equal to 16 ounces or 1 pint of milk. And at that point, we had 6 of the 18 who could tolerate the full 16,000 with no symptoms. 3 could take that with mild symptoms. 4 had some symptoms between 40 and 112,000. 3 were not eligible to continue because we predetermined that if they couldn't get to a certain point, they wouldn't be able to go on to this open label phase. And there were 2 who had ongoing symptoms. So the proof of concept was there. It really looked like something was happening. Reactions were common. So not surprisingly, reactions were a lot more common in active treatment than placebo, but that's why you have a placebo group, to really see if that's truly the case or not. There's a lot of anxiety in taking something you're allergic to every day. In the course of this study, we had about 4,000 cumulative doses because they're taking a daily dose, and there was some reaction in almost 50% of all doses. Most patients were, most reactions were mild, oral itching, itchy throat, self-limited, would go away without treatment, but all patients had some reactions. And more significant reactions like GI reactions occurred about 20% of doses, respiratory in 9%, and multi-system reactions in about 1%. 1 patient had to drop out because their eczema flared so severely. When we look at medications that were used, about 10% of all doses required treatment with an antihistamine, about 1% with albuterol, and there were a total of 9 doses of epinephrine given, and you could look at that as a very positive or very negative. 9 doses might be a lot, but it was 9 doses out of 4,000 doses given. So proportionally, it was a very small number of doses that caused a bad enough reaction to need epinephrine. What I mentioned before is that reactions are very unpredictable. They did become less and less common, thankfully, over time as kids got more and more desensitized, but there were reactions that were severe and surprising after people had taken the same dose for a period of time without any obvious difficulty. We have been able to identify some very specific risk factors for these reactions, and the one that's turned out to be the most common and really very, very interesting is exercise. And what we found is that when we looked at most of the unpredictable bad reactions, most of them occurred when children exercised vigorously within 2 hours of taking a dose. The second set I mentioned is part of the COFAR, which stands for Consortium of Food Allergy Research. And this is a NIH-sponsored consortium of 5 centers in the United States that have been charged to do studies on potential treatments for food allergy collaboratively. And in this study, what we did is looked at egg allergy. We again had a double-blind, placebo-controlled design, although it was more on active and only 15 on placebo. We did not do a food challenge at baseline for a variety of reasons. We escalated in this study to a dose of 2,000 milligrams. And part of that was because we learned in our milk study, not that you can necessarily equate milk and egg, but we learned in our milk study that it wasn't hard to get to 500 milligrams. And we've had a sense that higher maintenance doses might actually work better. There was an unblinding after 12 months. And then we had one of these, what we call tolerance challenges, where if they passed the challenge, they were then taken off the egg for 4 to 6 weeks and had a repeat challenge done. Again, that was to see if they were more permanently or at least desensitized in a longer-term fashion, if not permanently, or whether it was something that was going to come back fairly quickly. So here's the first challenge. This was after 1 year of treatment, and we're looking here at the placebo group, where there were just 15 in the group. 2 dropped out. and all of the rest failed the challenge, so that, not surprisingly again, because these were children who we didn't expect to outgrow their allergy, everyone who made it to the challenge was still reacting. In the active group, 5 dropped out, 13 failed the challenge, but 21 passed the challenge, so that we had, again, a signal that there was a significant amount of desensitization going on where kids could tolerate something they couldn't tolerate before treatment. Now, when you look at the percent of withdrawals, it was very similar, but it really turned out that the 5 people who withdrew in the active treatment group really did withdraw because of symptoms. And as we saw in the milk study, even though there was only 1 of the 20 there, in most of our studies there have been between 10 and 20% of the participants who can't tolerate the treatment. 4 of these 5 couldn't tolerate it because they got really chronic abdominal pain. It wasn't because they had acute anaphylaxis, but it was these low-grade reactions that forced them to stop taking the egg immunotherapy. Then on the next set of challenges, so the first row here is actually just what I showed you in the last slide, that 22 out of the 40 passed the challenge after the first year of treatment. After the next year, 30 out of 40 passed it, so we were up to 75% could take, at this point now, a 10-gram challenge equivalent to 2 eggs. But the key line, I think, on this slide is the next one. That's this line here. And what this says is that now we had 11 out of 40 who passed the challenge. And if you do the math here, that means that 19 of these 30 were only transiently desensitized, that they became reactive again within 4 to 6 weeks of stopping their egg. The longer-term follow-up is that of those 11 people who were doing well, they're all eating egg without difficulty. We're continuing to follow the other kids. Most of those who failed that challenge went back on treatment, and a number of them have now gone through their subsequent challenges, so that 36 months, 7 passed the tolerance, so meaning the time off of egg, oral food challenge, and are now eating ad lib egg. We're out to 4 years on the last 7. 3 have completed the 4th year, and they actually were not tolerant. So even 4 years of treatment didn't cure their egg allergy, and 4 others are going to be finished in the next few weeks. So the summary of this study, which was published in the New England Journal this past summer, was that about 75% were desensitized, but only about 25% had sustained unresponsiveness. We use the word tolerance in the paper. The New England Journal asked us to use the word sustained unresponsiveness as something that's probably a little bit more accurate. There were 7 additional subjects who could pass the 36-month tolerance oral food challenge. So our conclusions were that oral immunotherapy for egg desensitized a high proportion of children with egg allergy, but that it only induced sustained unresponsiveness, or something that might be nearly a cure in a small subset. And the last thing I'm going to mention is our next milk study. We're now doing our 3rd milk study, but our second one took a step back and said that we're doing, we have these 2 methods out there, sublingual immunotherapy and oral immunotherapy, and this was a study to compare the 2. And the difference here is that with the sublingual, you're giving a liquid drop. This device is designed to give the drops behind the bottom teeth, so you're giving it in the sublingual space. The oral is actually a dry milk powder. The most important thing here is that the dose you can give sublingually is actually quite small compared to the oral dose. The oral dose in this study, we compared 1,000 to 2,000 milligrams, whereas the sublingual dose, we only gave 7 milligrams. And it turns out that's the most we could give, because you're limited on the amount you can give sublingually by both the concentration of the material and the volume you can put in the sublingual space before someone starts to choke or gag, or in this case, 2 kids actually aspirated on that amount of milk under the tongue. And our basic outcomes represented here, after 15 months of maintenance, we saw a few kids in the sublingual side who did well. We saw an overall increase in tolerance in the sublingual side, up here to about 2,500 milligrams compared to 40 milligrams at baseline, but the oral group did dramatically better, so that most of the kids in the oral group could take the full 8,000 milligram challenge. And we were impressed enough by this difference that we actually went back to the FDA at this point and petitioned to offer oral immunotherapy to the kids on sublingual, and all of them who were down in this range did that, and actually managed to get up in this range with oral immunotherapy after not getting there with sublingual. The reaction rates were fairly similar between the oral and sublingual, but when you broke them down, it turned out that the sublingual reactions were almost all mild and localized, not surprisingly because the dose was so much smaller, whereas the oral immunotherapy caused reactions at a rate that are similar to what I showed you in the first study, with some GI symptoms, some hives, some respiratory symptoms. And when you look at rescue medication use, in the sublingual, antihistamines were only given in 1% of doses compared to 16% in oral immunotherapy doses. So not surprising, the low-dose slit was safer, but the first time ever shown in a comparative study, it didn't work as well. Again, back to this idea of tolerance challenges. So if we look at the side here that got the oral immunotherapy, we had 14 out of 18 who passed the full desensitization challenge, and we did something different in this study. Instead of waiting 6 weeks to re-challenge them, we actually did one challenge 1 week off, then another one 6 weeks off. And our question there is how quickly might people lose protection? And it turned out that a couple kids lost protection very quickly, so that 2 of these 14 had reactions after just 1 week off, and then another 4 had reactions 6 weeks off. So it looked a lot like the egg, that you could desensitize most, but many kids will get reaction back if they're not taking it on a regular basis. This is a baseline challenge in one of the milk immunotherapy patients. This was getting a minuscule amount of milk, total body hives, head-to-toe hives, not a spot in his body not covered. And when this stuff works, it is really fun. This is him after his study. And he can literally eat a whole pizza, followed by his ice cream sundae. We've looked, though, and really thought about, okay, how excited should we be? And we think we should be very excited about the potential, but also very worried that we have a long ways to go to really have this ready to bring to the general public. And this is just sort of reminding us about the lack of maintenance once you stop the medication. And the green line here and the blue line are the 2 things I showed you already, the egg study here and the milk study here, where some lost it after a week in the milk and then even more after 6 weeks. Kari Naidu out at Stanford has done something braver than what I've been willing to do, in that she has done peanut immunotherapy and then kept kids off now for a whole year. These are her data out to 6 months. And what she did when she re-challenged them after 4 months and then at 6 months was found that kids are still losing tolerance even out at this point in time. And that's one of our worries, and we're not as worried about this with milk or egg, where we think it won't be that hard for a child to keep some milk or egg in their diet on a daily basis. But we really learned that most kids who get over a peanut allergy routinely detest peanut, and to keep it in their diet is not going to be easy. And if a family's not very compliant, the child may actually be at much higher risk after being treated than they were before being treated, because they may stop peanut for a month, think they're fine because they were eating peanut a month ago, and now have reactions that were every bit as severe as they had before being treated. So the summary of this is that we think that sublingual is less effective. So more of our attention right now is being put on the oral immunotherapy in terms of thinking about ways to bring something out to the general public. We think that in these small studies I'm showing you, and again, these are small studies just proving whether it could work or not, that oral immunotherapy is capable of inducing significant changes in the threshold of reaction. That tolerance, again, in quotes here, is only accomplished in a minority with the current studies we're doing. That rates of adverse reactions are very significant. We need to be very mindful, but they're probably acceptable if we get a good enough outcome. The lack of long-term tolerance, as I just said, is a huge potential risk that we cannot minimize. We think this clearly deserves future study, but that right now is still very much in a research mode. This is not really ready to be done out in general practice yet because of all these unanswered questions and the need to do larger studies with hopefully better outcomes. There are lots of things going on right now. These are just a list of the things that we have going on at Hopkins, planned for 2013 and 14. We're currently doing right now a combination of anti-IgE and milk immunotherapy. We're starting a new COFAR-sponsored oral immunotherapy for egg. We're doing this peanut patch study, again, another COFAR study. We're starting the world's first wheat immunotherapy. We're starting a tree nut immunotherapy. We're looking at young kids for peanut immunotherapy. We think that sublingual may actually work better if we can do a higher dose. And one of my faculty's developed a dissolving film that can put a higher dose under the tongue. And one of our big questions is, can we do this with more than one allergen at a time? Because people sitting in this audience who take care of food allergic kids know most of our patients don't just have one food allergy. So if they need to go through multiple treatments, it will make it less feasible than if we could possibly do this in a multi-allergen kind of formula. There's lots of other stuff going on being studied in animal models. We expect progress to be, for the public out there, disappointingly slow. It should be slow because safety has to dictate how this moves forward. Funding is certainly an issue, but even if we had unlimited funding, this is something that needs to move forward in a very safe and deliberate manner. And even though I'm excited that this is something that can move forward and has the potential to be out in the community in the next 8 or 10 years, I'm still hoping that we will have much better methods eventually. What we're doing right now has promise, but it is difficult. It causes reactions. It doesn't cure most people. So I really think, I hope to be out doing this for another 15 years or so, and I hope in 15 years we're doing something very different than what I'm doing today. Even though what I'm doing today is very exciting and very promising, there's got to be a better way, and I think we'll be able to find it. Just credit a few of my many, many collaborators. I couldn't do any of this without my clinical and laboratory collaborators. And then the Consortium of Food Allergy Research has been a huge initiative. There was never any dedicated NIH money going toward food allergy until the consortium was started in 2005. And we've been able to get a lot done by putting together, rather than competing for money, by combining the resources of these 5 centers in the United States, led by Hugh Sampson and Scott Sisher in New York, Wes Burks in North Carolina, Stacy Jones in Arkansas, and the group in National Jewish Hospital in Denver with Donald Leung, Andy Liu, and David Fleischer. So this is something that we think will help move the field forward, and credit the NIH with sort of forward thinking about how to take the limited resources they have and make the most of it. I'll end here with, again, a great appreciation for the honor of giving this lecture. Hopefully it's been of some value. I think food allergy touches most of our lives in some way. So there was hopefully some piece of this that was gave you some information to take home or back to your practice. And I will be delighted to take questions both here and then at the reception afterwards. So thanks very much. Yeah, I'll repeat it.
So thank you so much, Dr. Wood, for coming. I think everyone was scared when you told us the story of someone in ICU and dying, even though they had epinephrine administered to them. I'm just wondering how rare is it that, how often does it happen that someone has 2 EpiPens and is, maybe 20 minutes from a hospital and is still need to be near a hospital at all times? Should I carry steroids with me in addition to the EpiPen?
Yep, so I'll repeat the question if people can't hear it. So the question is, how scared should we be? Is epinephrine always going to be life-saving? Do we need to, sit in the parking lot of the emergency room all the time or only part of the time? And the good news is that there aren't many stories of people who got epinephrine promptly and had a fatality. The bad news is there are a few stories where they got epinephrine promptly and had a fatality. So for our patients, I would love to be able to say that I can promise you from 25 years of doing this that no one has ever died if they got epinephrine right away. But there are a few. But the basic message, though, is still the really important one, is that virtually all of the fatal episodes have been with delay in administration. There was just one in Baltimore a month ago. It was an absolute typical story. 19-year-old, known peanut allergy, bad asthma, ate a cookie, felt horrible, went into his room, took his inhaler a whole bunch of times, came out an hour and a half later, and died on the living room floor. And that's the story that almost always is. And I really believe that there's a 99% chance that if he had done his epi right away, he would be alive right now. Yes, ma'am.
First of all, thank you so much. It was very informative. For kids who are allergic to wheat and IgE positive, do you check the SIGA with GI symptoms if they have?
So if they're allergic to wheat and are IgE positive, the rest of the question?
And also if they have GI symptoms, do you check their SIGA?
Their
secretory IgAs, IgGs, and if they...
So you're asking about celiac disease or?
Not actual celiac, the sensitivity.
Yeah, so ask me again if I don't answer right, but there are several different ways that a problem with wheat may manifest, and one is with sort of a typical IgE-mediated reaction. Wheat allergy can be really severe and scary, and those patients who have an acute IgE-type wheat allergy should practice strict avoidance, and that's about all we have to offer them. Again, we're starting a wheat immunotherapy study, which hopefully can help. There's another reaction to wheat with an immunologic reaction in the category of celiac disease, and that is another problem that unfortunately requires strict avoidance. We don't have anything else we can really do to protect them. There are other people that don't fit into a clear-cut category but appear to tolerate wheat very poorly, even though you can't identify any immunologic reason for that. And that can show up usually with GI symptoms, maybe other symptoms in some people. Those people may be able to tolerate some amounts, may not need to be on as strict avoidance, but the world of gluten intolerance out there is a huge one right now that has a lot of vagaries in terms of people that don't fit in any of the usual categories.
Thank you.
I was just wondering, do you recommend a skin test versus a blood test based on certain criteria, whether it's age or...
So we don't automatically recommend one over the other. We do look at them a little bit differently, though. And we look at the skin test as being a very useful screening test. Again, not a great test because there are a lot of wrong results, a lot of false positive tests. But we look at it as giving primarily a yes-no answer, having a little quantitative ability in terms of the size of the skin test response, but not a very reproducible quantitative ability. So one kid's skin test may vary twofold in the course of a week. We look at the blood test as also being a useful screening test, also being fraught with false positive tests. Neither of them is superior in terms of its specificity. They're both bad tests in terms of their specificity. They're about equally sensitive. The blood test now is a little more sensitive than a skin test. We look at the blood test, though, as being more quantitative and something that you can really use to monitor someone's allergies over time, much more so than a skin test. So once someone has been identified as clearly allergic to a food, we will use the blood test more than the skin test for ongoing monitoring of that particular allergy. Yes, sir?
Do you think the evidence is strong enough to make the recommendation to avoid solids till 4 months of age, or in the delivery room, give them a peanut butter sandwich and get them started as early as possible? And the second would be is in children that you're going to desensitize, what's the incidence of eosinophilic esophagitis, down the road as they get older?
Yeah, so the first question, there's not evidence to do anything one way or the other. So if you told me you wanted to, start your baby's on peanut butter, I'd say fine. If somebody else told me they didn't want to do it till they're 5, I'd say that's fine too. We really don't have, there's really not evidence that one method is superior to the other. The eosinophilic esophagitis is a very important question, and we do know that there have been a few cases of clear EOE that was probably induced by the food immunotherapy that resolved once the immunotherapy was stopped. We also know that the most common reason that the 10 to 20% of children in our studies drop out is abdominal symptoms, and most of them don't get scoped. So there is probably a higher incidence than what's been identified histologically by doing endoscopy. So if I was to make an estimate, I would say that there's a 5 to 10% risk of getting eosinophilic esophagitis from food immunotherapy.
I think I can speak
Yeah.
louder. I'm just curious with the IgE levels, if my child's rise every year, although there's really been no issues, no exposure that I thought, does it necessarily mean he's getting micro-exposures?
No.
I'm just curious about the levels, the RAS testing, the levels.
Yeah.
How much do you pay attention to that? It sounds like.
So we pay, so which food or foods are you talking about? Peanut, okay. So it actually makes a little difference for food, although there's no food for which we would assume that rising levels mean exposure. We don't think that at all. And with peanut, when you break down peanut allergy and look at the 80% of children that have persistent disease, their IgE levels almost always go higher, and we think that has been programmed very early on and has nothing to do with a degree of avoidance or exposure. We published a paper this past summer on 900 kids with peanut allergy. There are about 25,000 peanut IgE levels in that paper. And what you'll see is that they virtually all rise up to the age of 6 or 8, and then they kind of plateau. So we do expect in the majority of kids with peanut allergy who have persistent disease that their levels will rise over time. We pay no attention to them except as confirmation that your child is planning to keep his allergy. That's all. We don't make any inference in terms of reaction severity, risk. We don't make any inference in terms of him sitting at a different table at school, anything like that. It doesn't have any implications in terms of our action plan, our day-to-day management, but is confirmation that the allergy is going to hang around. Yeah. Yeah, so the question is that same for tree nut, and it behaves similarly. They don't rise quite as much as peanut in a lot of kids, but again, it's a useful test to monitor over a few years' time, and usually kids who have persistent allergy will go higher, maybe not get quite as high as the peanut for some reason, and the kids who might outgrow it stay low and go lower.
I have a daughter who has a severe peanut allergy, and she's had 2 escalating reactions. So we know she has the allergy, and her numbers are high. I also know that she has eaten at Chick-fil-A and Five Guys that are peanut oil.
Uh-huh.
And is that the whole idea that if it's cooked, it's okay? And I don't do it anymore, but we used to do it without knowing or thinking about it.
Yeah, so it's a very common question, and so the reality of peanut oil is that most of it is completely safe. And if an oil has been processed sufficiently, the protein has been removed. And the peanut oil supply in the United States, 98 or 99% of it is protein-free and completely safe. We see lots of peanut oil reactions from that 1 to 2% that's out there. Chick-fil-A is probably a fairly good example because they've actually publicly gone on record as saying that they only use safe oil, and we see Chick-fil-A reactions with some regularity. So I think it's actually a sign of how difficult it is to be really confident that the oil you're getting is really of that pure variety. So our general recommendation is that peanut oil is best avoided, even though with any given individual exposure, the risk of having a problem is very small.
Right here.
Right over here.
One more
Dr.
question.
Wood, thank you. Great talk. Appreciate it. Ted Sebastian. I'm a dermatologist here. So I look at this from the other side, and so I see a lot of kids with eczema, especially now. Winter's coming on, a ton of atopics. And so the mother will always ask me, well, food flare, is there anything we can do? And, I can't say that I've really seen that many patients, I've been doing this about 20 years, that tell me that when they eat a certain food and they get a rash. Every now and then I'll hear that. But we see a good volume. And I'm just wondering if I'm missing this. Is there something I should be? I always ask, do you have hay fever, asthma, sinuses, wool itch, cats, anybody in the family with allergies? And I'll get positive responses there that historically someone in the family or a sibling has another type of reaction that is reliable to mean they are an atopic family. But from the aspect of, does a food ingestion actually cause eczematous flare? I don't really see that often. I'm just wondering, what should I be asking? What should I be looking for? Maybe I'm missing something.
Well, there is a number of studies that give them fairly consistent results, that if you go into the population of severe eczema, that between 30 and 40% of the kids will have identifiable food allergy that could be a contributor to their disease. Now, some of them, you'll find that peanut allergy, but they're not eating peanuts, so in that case, it's coexisting but not contributing. But there will be a group of kids that do have, say, an egg allergy, where avoiding the egg will make it much easier to control their disease. Our sort of general guideline for who to worry about are the kids who respond well to your usual methods are much less likely to have a problem. The kids have really been recalcitrant and failed to respond to the kind of topical care you're recommending that works for the majority of your patients. May have an underlying factor like food allergy that would be worth exploring. The exploration can be done fairly simple in that it really is a small number of foods that account for most of that. And if you do RAS testing, IG testing, to 5 foods, milk, egg, soy, wheat, and peanut, and they're all negative, you've ruled it out. If they're positive, there are a lot of false positive tests, so that doesn't guarantee. If they're positive and you withhold the food for 3 weeks, they don't get any better, we would not withhold it any further. And there's a hidden risk in doing this, in that there are children who do have very significant allergy that is presenting only with eczema, who after a period of avoidance will have anaphylactic allergy to that same food that only caused eczema previously. So we actually talk to them seriously about the possibility that they should keep that food in the diet, even though it's going to take some extra triamcinolone on their skin to keep it under control, because there's actually risk of withholding that food.
Thank you.
Doctor, I'm Bill Dolan. I'm oldest and dumbest of the crowd. And I want you to know my father regrets at this moment that he was not here to hear this lecture. You represent his aspiration that we could expose a community hospital, its medical staff, the students, and all the caregivers here to people of your quality. And particularly would he hear, not only do you do the research that's world class, but you have a clinic where you're treating patients every day and you're teaching. And there is no fuller part of life for those of us who admire what you do and the good of all mankind that you bring. So to say thank you is also a tribute to you, and that your presence here is a great tribute to this lecture. And we thank you. Thank you. And Dr. Wood, I also have to tell you 2 other things. Dr. Dolan's grandchildren are here. And you saw Master Jack, because, Jack, raise your hand so everybody sees. Jack is our hope for perhaps medicine in the next generation. But there are 2 others. Kathleen, raise your hand, Kathleen. If anybody here is in the securities business, don't be talking to her. She's from the SEC. And her brother, Tom, who most of you know or have read about, has the best documented case of asthma in the world from 2 Olympic cycles. And Kathleen has the best documented peanut allergy in our family. So they are particularly bound to your story. And then I have to introduce to Dr. Wood and all of you the newest Dolan. Tom and Mary Ellen Gleason were married in September, so I'd like to introduce to the Dolan lecture Mary Ellen Dolan. My father would continue to be disappointed because she's a lawyer as well. But such is life, and things go on now. Ladies and gentlemen, we thank you for coming. It's a special night for this family, for this lecture, for this hospital that remains very much a part of all of our lives as it continues to aspire to be a community-based, university-affiliated deliverer of world-class medicine. We invite you to a reception in the atrium. That's normally a problem, because finding the atrium is a real task around here. But now there are blue signs that will direct you to the atrium. And those of you who might have a few more brief questions, for Dr. Wood. He's agreed graciously to stop in at the atrium for a while. But we thank you all so much, and to you, Doctor.
Thanks.
Also, there were a couple coats that were left in the room that are out on the entrance table now.
Your frustration level from the scientific
How's it going?
I admire that. Nice to meet you. How are you? Nice to see you. Oh, nice to see you. Thank you. Oh, that's wonderful.